Going ahead with another important drug with respect to treatment of heart failure, also in reducing the incidence of hospitalization, etc. This drug was asked in the previous exam. Okay, so these two were the reasons why we had placed these topics. Okay, one was already asked previously, so we thought if SGLT2 was asked, ARNI might be asked. So please go through these drugs again, okay? Or else please look into any drug that has come into picture into the clinical practice and which has been discussed quite frequently. So please read them. So they are probably one of the drugs that will be asked. Drug, there will definitely be one question in your exam. Okay, so please focus and read about them. So coming to the topic per se, sodium glucose transporter 2 inhibitors. So I'll be discussing under the following outlines. Okay, so sodium glucose cotransporter 2 inhibitor or SGLT2 inhibitors act primarily in the kidney, specifically in the proximal convoluted tubule. If we are talking about specificity of the PCT, it is acting on the S1 segment. Okay, so what does it do? So what is the mechanism of action of SGLT2 inhibitors? So as the name suggests, it causes glucose reabsorption inhibition. Okay, so under normal conditions, in a normal patient, SGLT2 is responsible for reabsorbing roughly around 90% of the filtered glucose from the renal tubules back into the bloodstream. But if you give these patients a SGLT2 inhibitor, it prevents this glucose reabsorption from the proximal tubules and cause glycosuria. Okay, what essentially it does is it reduces the renal threshold for glucose. And along with this, we told it is sodium glucose, correct? Both of them are involved. So what it does when this is inhibited, SGLT2 also plays a role in sodium reabsorption. It inhibits sodium reabsorption, causing overall sodium load to get decreased. How does it do this? It causes natriuresis, that is removal of sodium in the urine. Okay, and because there is glycosuria, removal of sodium, there will be a net loss of calorie, okay, or power in the body, and that causes a calorie deficit in the body. Okay, so because there is calorie deficit, there is osmotic diuresis, all and natriuresis. All of this would reduce the blood pressure. Okay, so there will be some amount of reduction of afterload in such patients. Mind you, despite SGLT2 causing glycosuria, natriuresis, calorie deficit, and osmotic diuresis, this does not activate the RAS system. That is one of the major important characteristics of SGLT2 inhibitors. Okay, in the previous talk in ARNI, you saw what happens when RAS system activation. RAS system usually gets activated in patients with chronic cardiac disease, chronic renal disease, correct? So both of them, because RAS gets activated, because sympathetic nervous system gets activated, there will be a lot of volume overload state, and at the same time, because of organ failure, inadequate removal and sequestration of fluid which happens in the body. So we need to look at alternate ways. One, always we look at diuretics. Other than diuretics, if there's any other drug that we can use, the other one is sodium glucose inhibitors, that is SGLT2 inhibitors. What are the physiological effects of SGLT2 inhibitors? One, on glucose metabolism, I told you it causes glycosuria, and because it causes glycosuria, it decreases the HbA1c in the long term. How does it do? It improves the insulin sensitivity in these patients, and because of which there will be better tolerability of sugar and lesser fluctuations, and that is how the patient has a drop in HbA1c levels. Okay, coming to metabolic effects, because of glycosuria and volume loss, there will be weight loss to the patient. There will be reduced visceral adiposity, which is usually a consequence of increased sympathetic overdrive, and there will be improved lipid profile also in these patients. Coming to the cardiovascular impact of SGLT2 inhibitors, I told you there is no activation of RAS in this patient, and there is decrease in excessive fluid in the body, there's decreased afterload. So there will be less stress on the heart. There will be balance in the demand and supply. Okay, and that is how there will be reduced cardiovascular events. There will be improved heart failure outcomes. That is, the risk of readmission due to failure in such patients will come down. Okay, and because all of this is also going to have a direct effect, that is your metabolic effects, this causes decreased atherogenic progression. How does it affect the kidney? It reduces albuminuria, preserves the glomerular filtration rate, and in the long term, it also slows down the progression of kidney to a CKD. Okay, so these are the physiological effects of SGLT2 inhibitors. You have to write it under glucose metabolism, metabolic effects, cardiovascular, and renal. Okay, so this is how we need to talk about the physiological effects of SGLT2 inhibitors. Coming to pharmacokinetic properties, usually the bioavailability of SGLT2 inhibitors orally is usually around 60 to 80%. It's always a tablet, correct? So the bioavailability is as high as 80%, and 80% is protein bound. The T half is roughly around 10 to 12 hours. Sometimes, depending on the drug, it can even be up to 24 hours. Okay, there are two generation of drugs. Based on a generation, the T half changes. Metabolism is usually hepatic, and glucuronidation is the way it goes, and it has very minimal effect on the CYP pathway. Okay, that is your cytochrome pathway. Renal elimination is approximately 50%, and the rest remaining 50% is excreted by the feces. Okay, so you have to remember it has a 50% bearing on the renal parameters. So directly we have to keep in mind about the effects of this drug when we are treating patients with chronic kidney disease. Okay, so this is what is the take home from pharmacokinetic properties. It is available as a tablet. The oral bioavailability is 60 to 80%. 80% of it is protein bound. T half is between 10 to 12 hours in first generation, and second generation it can go up to 24 hours. Hepatic metabolism is what it undergoes, and majorly it undergoes glucuronidation, and elimination is renal predominantly up to 50%, and the rest of the 50% is by feces. Okay, it just gets excreted. What are the examples of SGLT2 inhibitors? Dapagliflozin, empagliflozin, canagliflozin, and ertugliflozin. So there are two generations I told you earlier. The first generations are dapacana and empagliflozin. Second generation is sotagliflozin and ertugliflozin. Okay, sotagliflozin has a dual advantage of having to block both SGLT1 and 2. Okay, so as of now, we are not dealing with that, but majorly we're looking at SGLT2 inhibitors. Okay. So dosage considerations when we are looking at it, base, I told you excretion is majorly renal up to 50%. That is where it comes into picture. The starting dose is usually around, if you're taking DAPA and EMPA, that is what is commonly used in Indian settings. If you're taking dapagliflozin, usually they start with 5 milligrams daily, and the maximum dose is up to 10 milligrams per daily. If the GFR is less than 30, it is contraindicated. Usually, there is no renal adjustment necessary for DAPA and empagliflozin, but in canagliflozin, there is renal adjustment which is required if the GFR drops less than 60. Okay, so that is one of the major reasons canagliflozin has been removed from routine care, and DAPA and empagliflozin is still being used. The major advantage is it can be still used in patients with CKD up to a patient whose GFR is more than 30. Okay, so that is the cutoff. Coming to potential adverse effects associated with SGLT2 inhibitors, so commonly it causes mycotic infections, urinary tract infections, volume depletion. Okay, that is because of glycosuria and natriuresis. Okay, rarely it is known to cause euglycemic diabetic ketoacidosis, which commonly we see in patients who come to the ICU with the sepsis with the background of SGLT2 inhibitors. Okay, so always, if at all you get your reconciliation and the patient has this SGLT2, if you find that there is some amount of ketosis present in the patient and you have a decay setting with euglycemia, that time probably it is because of SGLT2 inhibitors. Okay, it is also known to cause acute kidney injury because of volume depletion, and rarely it is also known to cause bone disease. Okay, having said this, okay, we saw what are the advantages. We also saw what are the disadvantages. The major thing that we need to understand based on multiple RCTs is the risk overweigh, the benefits overweigh the risk. Okay, so it has very minimal risk as compared to the benefits which it's throwing at us. Okay, so that is the reason most of the societies, like you saw in the previous presentation, it has a class 1 recommendation, especially in patients with heart failure with a reduced ejection fraction, and with patients with moderately reduced ejection fraction as well. Okay, so coming to the role of SGLT2 in critical care per se. Okay, till now we generally saw what is SGLT2 inhibitors. I talked about the pharmacokinetics, pharmacodynamics, and what are the adverse effects, and what are the dosing. So coming to role in critical care per se, first and foremost, remember, if the patient is having clinical instability in the ICU, we cannot use this drug. Okay, or it's always better to keep a watch. If the patient's GFR is very low, if the patient is on end-stage renal disease, we cannot use this. Okay, if that is patient requiring dialysis. Okay, so if the patient is not having any such things, then we can start initiating the patient on SGLT2 inhibitors. Okay, how does it act? What is the role? So two things we looked at: natriuresis and glycosuria. Natriuresis helps in optimizing the hemodynamic effects, and glycosuria helps in metabolic effects. Okay, so what does it do? Natriuresis decreases the plasma volume and decreases the blood pressure and reduces the risk of heart failure. Similarly, insulin resistance is reduced, body weight is reduced, ketotic metabolites are increased, and the ketotic metabolite is usually the substrate which is required for the cardiac myocyte. Okay, so thereby it helps in optimizing the cardiac myocyte metabolism, and thereby reduces the risk of development of heart failure. Okay, so role of SGLT2 in heart failure, if you have to answer it, it is under these topics. Okay, firstly, it is multifactorial. Okay, first is diuretic effect. Okay, so I told you earlier, it does not activate the RAS pathway or the sympathetic nervous system. So that is a major plus point. Okay, again, it helps in desequestration. That is, it removes fluid from the interstitial cells, and then it helps in natriuresis. So that is one major advantage of SGLT2 in heart failure. The second important point, it reduces the preload. Okay, and it also reduces the arterial stiffness. I told you the atherosclerotic pathway would have come down. Okay, because it reduces the afterload, also there will be improvement in cardiac function. Okay, so diuretic effect, hemodynamic optimization, reduction in cardiac afterload, improved myocardial energy efficiency. So it shifts the substrate utilization from glucose to ketones, which is a more efficient fuel, especially to the cardiac myocyte. Okay. Along with all these three major issues, it causes long term benefits to the patient with heart failure. What are the long term benefits? It is an anti inflammatory, anti fibrotic drug. Okay. Along with this, since we are optimizing the demand supply mismatch in heart failure, it reduces the risk of readmission, and in the long run reduces the incidence of cardiovascular death with patients of heart failure. Okay, so this is the role of SGLT2 in heart failure: diuretic and hemodynamic effects, reduction of cardiac afterload, improved myocardial energy efficiency, anti-inflammatory and anti-fibrotic effects, and reduction in hospitalization and mortality. Okay, so this is the role of SGLT2 inhibitors in heart failure. So when do we initiate this? Okay, so primarily it can be used for outpatient, department candidates who come with IHT with reduced ejection fraction, even though they do not have any heart failure symptoms. Okay, it can be used as a preventive therapy. Or else, if you're using it for active management, it is recommended for patients with heart failure with reduced ejection fraction, that is an EF of less than 40%, with an NYHA grading of dyspnea between 2 to 4 after optimal medical management. Okay, so you start with optimal medical management with the four pillars for this thing, and one of the four pillars can include SGLT2 inhibitors as well. These things can be used in advanced heart failure as well, but usually if the patient has hemodynamic instability, the initiation of SGLT2 is kind of a double-edged sword. Okay, so what is the evidence that we have currently? So majorly, if you look at the two major candidates which we are looking at, one will be the patients with heart failure and reduced ejection fraction. The other group of patients would be heart failure with patients having preserved ejection fraction. Both of these cases have good outcomes. Okay, so level one evidence, as shown previously itself, you know that in heart failure with reduced ejection fraction, what are the trials? It is DAPA heart failure trials. The drug being is dapagliflozin. Empagliflozin also has demonstrated similar reduction in hospitalization due to heart failure, and it also has been shown to decrease worsening of CKD. Okay, so both these trials in the long run have helped the patient. Okay, So majorly because it involves both the heart and the kidney, cardiorenal syndromes, which usually happen because of prolonged heart failure with reduced ejection fraction, that can be offset. Okay. Similarly, if at all the patient has a preserved ejection fraction, is there a need for this? Definitely yes. You looked at what does it do for energy substrate utilization, anti-inflammatory and anti-metabolic pathways, correct? Anti-fibrotic pathways. So all of this is the one which we are focusing in patients with heart failure having reduced or preserved ejection fraction. Okay, so the evidence for preserved ejection fraction are Emperor Preserve trial, where empagliflozin was the trial, and Delaware trial. Okay, so based on both of this, now SGLT2 inhibitors, that is dapagliflozin and empagliflozin, are the first line therapies in guidelines for heart failure. Okay, in reduced ejection fraction, definitely it's the first line, irrespective whether the patient is having diabetes or not. Okay, coming to preserved ejection fraction, there is strong evidence, but again, it depends on person to person, and it's still level 2B. Okay, so class 2B. I'm sorry. So we have to still wait for larger trials to come and put it into a guideline perspective. Coming to mechanism of action in CKD, till now we looked at what it does to the heart, we look at the kidney right now. So major action, we know it acts in the proximal convoluted tubule, okay? And for it to act in the proximal convoluted tubule, majorly what it does is it restores the tubuloglomerular feedback, okay? Which enhances the sodium delivery to the macula densa. This leads to afferent arterial vasoconstriction, leading to intraglomerular pressure reduction, okay? And because of this, there will be mitigation of glomerular hyperfiltration. Okay, remember, glomerular hyperfiltration is a key driver for CKD progression, and this glomerular hyperfiltration would be blocked by SGLT2, and because it blocks glomerular hyperfiltration, it restores the tubuloglomerular feedback and slows down the progression of CKD. Okay, so along with this, it's similar to the anti-inflammatory effects, etc. also continues. Okay, so again, patients with diabetes, with diabetic nephropathy, etc., it helps in a better glycemic control and better insulin sensitivity. Okay, so all of this is also restored in patients. So, what is the clinical evidence for patients requiring SGLT2 inhibitors in CKD? The trials are DAPA CKD trials, Credence trials, all showed significantly slower rates of development of CKD in patients who have been started with SGLT2 inhibitors. Okay, again, SGLT2 inhibitors, the benefit is seen majorly in diabetics with CKD as compared to non-diabetics with CKD. So as of now, earlier on heart failure, I told you it can be given irrespective of diabetic status. But in CKD patients, when we are looking at it, better to give it to patients with CKD who have a background history of diabetes. Okay, that is one of the major take-home points I wanted to understand. Okay, so majorly because it reduces glomerular hyperfiltration, there will also be a reduction in albuminuria, which usually see in patients with early stages of CKD. What are the challenges and considerations? You should remember patients with low GFR, especially less than 30, it's usually contraindicated, especially if the patient ends up in ESRD, majorly because the drug will not act because the nephron is no more functional. Okay, so that is the major issue. Along with it, it is known to cause euglycemic ketoacidosis, urinary tract infections, etc., like I have discussed earlier on. Okay, what are the key applications? Heart failure, AKI prevention. Sepsis, it's still in research. We don't have major trials to tell for the routine user of it. Hyperglycemia, definitely in patients with diabetes and AKI or CKD. Okay, in such patients, it is known to have better glycemic control. Okay, so always be aware. What are the limitations? When you start using SGLT2 in the earlier phases, especially patients with CKD not on dialysis, there's a risk of volume depletion in such patients, okay, and cause hypotension. So always be careful about it. Along with this, patients with diabetes, they are known to cause euglycemic ketoacidosis, so it can be missed, okay. And one of the only ways we will know is the patient will be admitted to the ICU for some other reason, and then we might have to pick it up, okay. Always keep a watch for of the renal parameters for a patient on CKD. Suddenly these patients might develop end stage renal disease and end up on dialysis. At that particular time we might have to stop SGLT2 inhibitors. The first and foremost thing which I have to tell, and I still want to insist, is hemodynamically, if the patient has to be stable when you're thinking of initiating SGLT2 inhibitors. If at all you find this patient having shock on multiple pressors, better to avoid it. Okay, because if you start this again, it causes glycosuria, natriuresis. Okay, once both of them start, there'll be no way that you'll be able to stabilize the hemodynamics. Okay, so this is one of the limitations in critical care. So this is one article I just want you guys to look at. It's a beautiful article. It's a state of the art review for SGLT2 inhibitors. Okay, any questions, I'll be happy to answer. Thank you.